welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Hi everyone, I'm Elizabeth Caudill. I'm a PGY2 emergency medicine pharmacy resident at Brigham and Women's Hospital. Today I'm going to be talking about a non-inferiority randomized control trial of a shorter acetylcysteine regimen for acetaminophen overdose, the SARPO trial. The objectives for the presentation today will be to evaluate data on the effectiveness and safety of a shorter regimen in acute acetaminophen overdoses less than 30 grams. Since its introduction in 1955, acetaminophen has become the most widely used analgesic antipyretic in the United States. Acetaminophen is a component of hundreds of different medications used worldwide, and now studies estimate acetaminophen is involved in approximately 6% of all poisonings or overdoses. And prior to the introduction of specific antidotes, the rate of severe liver damage was over 50%. So now I'm just going to go into the metabolism and resultant toxicities with acetaminophen. So 90% of it undergoes glucuronidation or sulfation and is broken down into sulfate and glucuronide conjugates. And 2% is excreted in the urine unchanged. And then 8% is oxidized by CYP450 enzymes into a toxic substance called NAPK. This is then usually, under normal circumstances, rapidly conjugated with glutathione into non-toxic cysteine and mercaptate compounds and then excreted in the urine. However, in overdose scenarios, we rapidly deplete our glutathione stores, and that leaves NAPK hanging around longer. It is a toxic compound that can cause protein adducts and increased oxidative stress, which then leads to hepatocyte necrosis. Acetylcysteine acts as a hepatoprotective agent by restoring hepatic glutathione, serving as a glutathione substitute, and enhancing the non-toxic sulfate conjugation of acetaminophen. Originally, in the 1970s, they developed a 3-bag acetylcysteine regimen with the theory that upon a presentation of an overdose, we have depleted all glutathione stores and therefore need a large bolus dose in the beginning, and then would require an infusion over around the duration of action of acetaminophen, or maybe 5 half-lives of acetaminophen. So the original 3-bag regimen was developed as 150 milligrams per kilogram over about 60 minutes, followed by 50 milligrams per kilogram over 4 hours, and then finally 100 milligrams per kilogram over 16 hours, for a total of 300 mg per kg over a total of 21 hours. To simplify this regimen, people have come up with the 2-bag regimen, which consists of 200 milligrams per kilogram over 4 hours, simplifying those 2 first steps, and then is followed by 100 mg per kg over 16 hours. So again, for a total of 300 total milligrams per kilogram over 20 total hours. And the 2-bag regimen has been shown to be just as effective as the 3-bag regimen, and also come with fewer side effects of that rapid initial infusion of the N-acetylcysteine, which could present as GI side effects and as anaphylactoid type reactions. A third regimen has come about called the SNAP regimen, which is now used in the UK. It consists of 100 milligrams per kilogram over 2 hours, followed by 200 milligrams per kilogram over 10 hours, for a total of that same 300 mg per kg, but this time over a shortened duration of only 12 hours total. So what do the guidelines say? The 2023 American Academy of Clinical Toxicology consensus statements for the management of acetaminophen poisoning says that Over 15 different regimens had been identified, and comparative effectiveness had not yet been determined. So if the patient presents within 4 hours post-ingestion, they recommend to administer a single dose of activated charcoal, and then to obtain a acetaminophen level between 4 and 24 hours after ingestion to use on the nomogram, which I'll talk about next. And then finally, they just broadly say to use a regimen of acetylcysteine that delivers at least 300 milligrams per kilogram orally or intravenously during the first 20 to 24 hours of treatment. So now bringing us to the nomogram and the regimen most commonly used in the US now. So the nomogram on the right, basically you take an acetaminophen level between 4 and 24 hours and then plot that level on this nomogram. And if the level is above the treatment line, which starts at 150 micrograms per milliliter at 4 hours, then treatment with an acetylcysteine is recommended. And then if it is double the treatment line, which is the high risk line, starting at 300 micrograms per milliliter at 4 hours, then the standard regimen may need to be adjusted if the patient's concentration is over that high risk line. So again, like I said before, the standard 2-bag regimen is 200 mg per kg over 4 hours, followed by 100 mg per kg over 16 hours. So some prior evidence for this type of reduced duration in acetylcysteine regimen includes this study by Bateman et al. It was a double-blind randomized controlled trial at 3 UK hospitals from 2010 to 2012. They just similarly looked at acute acetaminophen overdoses, and they compared the standard 2-bag IV acetylcysteine regimen over 20 hours with a shorter 12-hour modified protocol that consisted of 20 mg per kg over 4 hours, followed by 50 mg per kg over 8 hours, which is essentially just the second arm of the standard treatment cut in half. So instead of 100 mg per kg over 16 hours, they cut that in half into 50 mg per kg over 8 hours. And the outcomes of this study, they found that the shorter regimen experienced fewer side effects, including less vomiting and requiring fewer antiemetics. And they actually saw that changes in ALT were similar between groups. However, this study was not powered to find non-inferiority in liver damage. So they concluded that further research would be needed to confirm efficacy. So that brings us to a non-inferiority randomized control trial of a shorter acetylcysteine regimen for paracetamol overdose, the SARPO trial. This was a multi-center, non-inferiority, unblinded, randomized control trial that was conducted at 3 Australian hospitals with dedicated clinical toxicology services, and they recruited patients from July 10th, 2017 to April 4th, 2024. They included patients who were over the age of 16 and who had an acute single acetaminophen overdose of less than 30 grams and greater than 8.5 grams, who presented within 8 hours from ingestion, and who had an initial acetaminophen concentration above but less than twice the nomogram line, which is also known as an acetaminophen ratio of 1:2. And the acetaminophen ratio terminology just means the patient's measured acetaminophen level divided by the level on the nomogram treatment line. So if it is above 2 or twice that concentration, it would be in the high-risk group. They excluded patients with any staggered or repeated supertherapeutic ingestions or ingestions of any modified released formulations of acetaminophen. So like I described before, we have patients who were allocated to the standard regimen and then patients who were allocated to the shorter regimen. And just to point out one more time, the beginning of the regimens start the same, 200 mg per kg over 4 hours. And then the second half of the treatment is just cut in half to 50 mg per kg over 8 hours. The primary outcome of this study was absolute difference between the ALT on admission and the ALT 24 hours post-ingestion. And the secondary outcomes included the proportions of patients with a 50% increase in ALT over their admission at 24 hours post-ingestion. The proportion of patients with a 24-hour ALT greater than 150 and greater than 2 times their admission value. Patients with ALT greater than 1,000 at any time post-ingestion, and patients with systemic hypersensitivity reactions or gastrointestinal adverse effects within the first 12 hours of treatment. So ALT data from 121 acetaminophen overdoses treated with a standard regimen was collected prior to the study commencing. In order to determine their non-inferiority margin, they took half of the upper arm of the 95% confidence interval of that change in ALT from baseline to 24 hours, and they found that the non-inferiority margin would be 10.7, or half of that upper 95% confidence interval arm. And the study investigators ended up deciding to choose a stricter, clinically conservative non-inferiority margin of 5 so that they could be very sensitive in detecting any difference in liver damage between groups. Randomization was done using the biased coin design, which is a computer algorithm that allocates patients randomly simulating a coin flip. However, if there ends up being more patients in one group over the other, then it self-implements a bias so that it can even out the groups and have an even distribution between the groups. And then tests were performed and the data was found to be not normally distributed. So therefore, non-parametric methods were used for the analysis, and descriptors such as median and IQR were used. So of 3,664 acetaminophen overdoses that presented to these hospitals during the time frame of the study, 2,477 of them had ingested a dose of less than 4 grams or had a non-toxic acetaminophen concentration and therefore were not treated with an acetylcysteine, so they were excluded. And then of the patients who were administered acetylcysteine, another 106 ended up getting excluded for finding that their levels were actually non-toxic. And then finally, of the 1,081 patients who were treated with an acetylcysteine and who had a toxic acetaminophen concentration, an additional 877 patients were excluded for reasons such as having a staggered ingestion, receiving an acetylcysteine greater than 8 hours after ingestion, or having an unknown time of ingestion, having consumed a modified release formulation or doses greater than 30 grams or less than 8.5, etc. So we ended up with randomizing 204 patients in this study, 107 to the short 12-hour regimen and 97 to the standard 20-hour regimen. The baseline characteristics were pretty similar between groups, with the median age being patients in their 20s, the majority of patients being female, and the median dose of ingested acetaminophen being 15 grams. However, there were some minor differences in the patient's median acetaminophen concentration, with a slightly higher concentration in the standard treatment arm. However, there was also a minor increase in acetaminophen ratio greater than 1.5 in the short group. That acetaminophen ratio, again, meaning being above 1.5 just puts you a little bit closer to that high-risk population. And then slightly higher percentage of patients in the short treatment arm had received activated charcoal on admission. So they found that the change in ALT at 24 hours was actually -1 in the standard arm and -2 in the short arm, for an absolute difference of -1, and a 95% confidence interval of -3 to 1. And again, the non-inferiority margin was 5, so the upper arm of that 95% confidence interval being 1 means that we did reach non-inferiority in this trial. All of the other endpoints were not significantly different. The change in ALT at 24 hours being greater than 50% was 8.2% in the standard group and 7.5% in the short group. 0 patients had a peak of greater than 1,000 at all at any time in this study. And then systemic hypersensitivity was similar between groups, with 10% in the standard group and 8% in the short group. And then notably, there were slightly more gastrointestinal effects in the short duration arm, with 72% as compared to 63% in the standard treatment group. So some strengths of this study include it was a randomized controlled multi-center trial, which can help improve its external validity by seeing a wide variety of patients and having been well designed. It also included a primary outcome that was objective at ALT at 24 hours, which increases its validity due to the patients and clinicians being unblinded in this study. So having an objective primary outcome helps to limit any bias that could be introduced by having an unblinded study. And then they used a rigorous non-inferiority design with a conservative margin of only 5 units per liter for ALT changes, which really allows for a very sensitive detection of differences in liver damage. Some limitations of this study include very strict inclusion criteria, which limits the applicability to a significant portion of acetaminophen overdoses. Like I said before, there were over 3,000 patients with overdoses who presented, and only 200 were randomized. I will point out that over 2,000 of them were not treated due to being very minor overdoses, but still, of the patients that were treated, over 1,000 patients were treated with N-acetylcysteine, and again, only 200 were randomized in this trial. So would really like to see more broad inclusion for further studies. And then patients and clinicians were unblinded to study groups, like I said, which could introduce some bias. And then duration of hospital admission was not assessed. So a big push for the reasoning for shortening treatment duration would be to improve quality of life, economic outcomes, treatment duration, and taking up hospital beds or ED beds. So all of these reasons are reasons to want to shorten the treatment duration. However, the actual hospital admission duration was not assessed, which I think really could have added a more patient-centered outcome to this study and given us a little bit more information about what really happened at the end of the day with these patients. So in conclusion, a shorter version of the 2-bag acetylcysteine regimen can be safe and effective for low to moderate risk patients with acute acetaminophen overdose. These outcomes should only be applied to patients within the parameters of the study, which were pretty strict, like I said. Acute ingestions of immediate release acetaminophen less than 30 grams, presenting within 8 hours of ingestion. And further research will be needed to elucidate the best ways of reducing adverse effects of acetylcysteine, because they unfortunately didn't find reduced adverse events in this study. So looking to the future, individualizing acetylcysteine regimens for lower risk patients could significantly shorten the length of treatment required and therefore duration of hospital admission for acetaminophen overdoses. And future research should investigate patients outside of this population, such as patients with staggered ingestions or patients presenting after 8 hours of acetaminophen ingestion, to determine whether further individualization of acetylcysteine regimens improve outcomes.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.